Dr. Oberoi has also joined. We are live. Sir, please unmute. Dr.
Yes, Shreyash,
IPS.
please continue. Shreyash, please.
No problem, IPS. We've got a minute. So, Dr. Miller, this is IPS Oberoi. He's the president of our society. And
Hi, Dr. Miller. How are you?
Pleasure to meet you.
Good to see you, sir.
Thank
You
you.
look in pink health.
We're trying. We're trying.
So nice to see you. So nice to see you.
IPS,
We are
please
live,
start
sir.
and then I'll take over.
Okay.
Perfect. Friends, good evening and welcome to our webinar today. And I think thanks to Dr. Shreyash, we have a join in arthroscopy, Dr. Miller, and Dr. Miller is from University of Virginia, US. And he's going to talk about revision ACL reconstruction. Where are we today? Dr. Shreyash will introduce our guest speaker. He is known to a lot of our Indian surgeons. Some of them have visited his center as well in the West. So if Shreyash, if you can kindly briefly describe about our guest today, and then we take forward for academic session. Thank you.
Thank you, Dr. IPS Oberoi. And hello, everyone. And welcome to this webinar on revision ACL reconstruction. Where are we today? Whilst ACL reconstruction is an established procedure, graft retear is not uncommon due to a variety of reasons. And this situation is disheartening not only to the patient in view of the repeat surgery and rehab, but also to the surgeon, even if he's not performed the primary procedure, as the success rates are inferior to a primary ACL reconstruction. And to share his years of experience and pearls on this topic, we have a renowned surgeon, Dr. Mark D. Miller from Virginia, USA. Welcome, Dr. Miller. Dr. Miller is a S. Ward Castles Professor of Orthopedic Surgery and former Division Head of Sports Medicine at the University of Virginia. He's a highly decorated retired colonel in the US Air Force. He's a distinguished graduate, top 3% of both the US Army Force Academy and the Uniform Service University of Health Sciences. Upon graduation from the Air Force Academy, he served as a civil engineer in the Air Force and earned his professional engineering certification. After medical school, he completed his residency in orthopedic surgery at Wilford Hall USAF Medical Center in San Antonio, Texas, and a fellowship in sports medicine at the prestigious University of Pittsburgh. He served as an attending surgeon and head team physician at the US Air Force Academy and as chief of sports medicine and deputy chairman at Wilford Hall USAF Medical Center prior to his retirement as the division head of sports medicine at the University of Virginia in 2000. He served as head team physician for James Madison University for over 15 years and earned 2 FCS national championship rings. Dr. Miller, as we all know, has published extensively. He has authored over 200 articles, edited 40 textbooks, and his best-selling Review of Orthopaedics is popular amongst all of us and certainly to me as a resident. And he's also served as the American Orthopedic Society of Sports Medicine as a representative editor of the Orthopedic Knowledge Updates Sports Medicine 5th edition. He has earned several publication awards for his textbook contribution. He has been named a top doctor on numerous local, state, regional, and national listings. He's mentored countless medical students, residents, and fellows at the University of Virginia and has given numerous lectures, conducted research, co-authored papers, and worked with them literally side by side his entire 25 years at the university. So really, he's a great teacher. He is perhaps best known for his many contributions to the education of medical students, resident fellows, and practicing orthopedic surgeons around the world. He has been recognized as outstanding faculty by orthopedic residents on 3 separate occasions. He's also a recipient of the Distinguished Educator Award and Outstanding Surgeon Outpatient Surgery Award at the University of Virginia. He's developed and moderated instructional course lectures at both the American Academy and the AOSSM every year for the last 20 years. He's founded the AOSSM Sports Medicine Specialty course and has chaired several other courses for the society. He served as an educational committee and council chairman, was the inaugural industry relations chairman, and was both a traveling fellow and a godfather. He served on the Council of Delegates, the Examination Committee, and the Traveling Fellowship Committee. Dr. Miller was an AOSSM program chairman and currently serves as secretary on the board of directors. He has received the George Rover Award for Education, the USUHS Distinguished Service Award, and the Virginia Orthopaedic Society Lifetime Achievement Award. He also was recently recognized as a co-winner in the inaugural AOSSM Masters Competition for lifetime contributions to innovation. He is selected as the incoming vice president of this prestigious society and will serve as a president during 2022 to 23 academic year. And we look forward to your presidentship, Dr. Miller. Dr. Miller's research interest includes complex knee, focusing on multi-ligament injuries, revision ACL reconstruction, articular cartilage injury treatment, meniscal repair and transplantation. So really, he's very apt to talk on this difficult topic on revision ACL reconstruction. Where are we today? I welcome you on behalf of the Indian Arthroscopy Society, and please go ahead and share your presentation. Thank you.
That's a very kind introduction. I appreciate that very much, and I'm humbled that that took so long. So please bear with me while we pull our screen up, and we're going to talk about a subject that I really enjoy to talk about, and that is revision ACL reconstruction. And so let me pull up the slideshow view. And so it's an honor to speak to you, and this is quite a prestigious group, and I'm pleased to share what I know about revision ACL. This is particularly difficult during this pandemic, and this is the way that we're all learning now, and there's some positive things to it. And so thank you very much. I'm honored to speak. Here are my disclosures. The only issue that is relevant is that I've helped Arthrex develop some tools for revision ACL reconstruction. So ACL graft failure may not be the end of the world if you're a surgeon, but it's a big deal if you're the patient. The way we're going to cover this is start with a brief introduction, then talk about common causes of ACL reconstruction failure that lend us to revision ACL reconstruction, and focus on one topic in particular, that is osteolysis or tunnel widening, which allows us to determine whether or not we plan for a 1 or 2 stage procedure. And we'll talk about each of those. Then we'll briefly touch on some of the studies we're doing at the University of Virginia, and as time allows, share some various cases. So in order to talk about revision ACL reconstruction, we first should talk about primary ACL reconstruction. And so if you get it right the first time, you don't have to do a revision. And so the way that I encourage folks to do this, especially beginners, is to make use of these new mini fluoroscopies that are available in most ORs, and to place your pins prior to drilling them and actually check them. So you can check them on fluoro before you over drill them, and that way you know tunnel is exactly where you want it. We've done several studies on this, demonstrating that even when you think you're in the right place, you may not be. And fluoro is a quick, easy, and efficient check before you drill your tunnels. So what causes ACL failure? Well, there's a combination of various different things. And the Moon group and Mars group has talked about this extensively and shown that there's basically 3 different causes of graft failure. This concept was first introduced at the University of Pittsburgh when I was there back in the early 90s. And there can be repeat trauma, technical errors, or failure of the graft. And more often than not, there's a combination of these factors that causes problems, as shown in this Venn diagram. Now, this is an image from our new Review of Orthopaedics 8th edition, and it is what I call a composite diagram. So it shows multiple findings on one figure, and it shows the various causes of ACL failure. Perhaps the #1 cause is abnormal tunnel placement or aberrant tunnel placement. And particularly, in general, community doctors will often place the femoral tunnel too anterior and too vertical. The verticality causes a rotational problem. The anterior causes failures of graft because it gets too tight. There's a variety of other problems also, all shown here: missed other injuries, also some problems with interference or button fixation, graft choices, etc. And I also want to focus on tunnel widening or osteolysis. So again, the most common error is abnormal tunnel position, especially on the femoral side. And as we indicated, vertical tunnels can cause rotational instability. So hardware failure is also a cause for ACL reconstruction failure, especially early. Obviously, interference screws need to interfere. So they need to be parallel with the graft and to basically give you a tight fit of the bone plug in that tunnel. And then cortical fixation devices rely upon the cortex of the bone in order to deploy. And so in revision setting, often that cortex is already disrupted. And so if you choose to use cortical fixation, you should use a larger button. Obviously, the fixation devices need to be in the tunnel. You have to have the screw in the tunnel. You have to have the button at the cortex, and you can cause failures if you don't get this right. You also need to identify and correct any concurrent injuries, such as a ramp tear, which is a very peripheral tear in the junction of the very most peripheral meniscus and the capsule, as shown here. You also need to address root tears and repair them at the time of ACL reconstruction. And then in some cases, you need to augment your ACL revision with either an ALL or a lateral extraarticular tendesis of a portion of the iliotibial tract. We've also noticed increasingly that slope problems can be an issue. And so if you have abnormal increased slope more than 12 degrees, you should consider doing a closing wedge anterior osteotomy at the time of your reconstruction. But one of the biggest problems is tunnel widening. And so this is not a problem that can cause ACL failure necessarily, but it's definitely something you have to address when you're doing a revision. And you have to think carefully about this and to study it before you jump into a revision case. So what causes tunnel widening or osteolysis? People propose it's either a windshield wiper or a bungee cord effect, but we're really not clear exactly what causes osteolysis. In fact, the Ohio State University suggests that there's actually some very low-grade indolent infection only detectable by polymerase chain reaction that causes some of these infections, or is at least associated with osteolysis. When you take a biopsy of this tissue, it's often fibrous with foreign body giant cells and debris. So how do we work up a revision ACL? We start with radiographs, looking at the alignment, also looking at the slope. You can get stress radiographs to make sure you're not missing a concurrent injury, such as a posterior lateral corner injury or an MCL injury. You can get MRI and MRI arthrogram if appropriate. And computerized tomography is perhaps the best way to look for tunnel osteolysis. Very helpful, and we've done a lot of studies on imaging of CT. So how do you fill this osteolysis? Well, there's multiple options: iliac crest, other grafts, bigger grafts, allografts. And so we have found that the best option is allograft bone dowels that we'll discuss. But whatever you choose, you first have to remove all of the fibrous tissue and debris and then put your graft in. This may or may not make you do a two-stage approach. One study showed that at time zero biomechanically that the press fit plugs or dowels is comparable to primary ACL reconstruction. We're studying this in the lab right now. So let's talk about these dowels. These dowels come pre-packaged. They come from cadavers, but they have no cells in them. And that's important because cells cause a host immune response. They're fully cannulated and bullet tipped as a result of some of our suggestions early on in this process, and we'll show you how this works. The bottom line with the dowels is that you place a pin right in the middle of your old tunnel and then drill serially at 2 millimeter increments, 8, 10, 12, 14, 16. until you get the picture on the lower right here, which shows nothing but bone in the tunnel. I call that tunneloscopy, looking up the tunnel with your arthroscope to make sure you've removed all the debris. And once you've removed all the debris, you can tap the equally sized dowel into that defect with a press fit technique that's very stable. So you can sometimes do this in one stage, particularly if you have tunnels smaller than 14 millimeters and it does not affect the location of your new tunnel. You can overlap these dowels a little bit, up to 40 or 50%, but no more than that because they'll simply fall out. Here's an example of a one-stage revision. We debride the old graft, we center the guide pin, we serially drill, and then we place the bone dowels in that location. Here we are placing that dowel. Here afterwards is the dowel. And then we can plan to do a little bit of a notchplasty and plan for our new tunnel, and then drill our new tunnel adjacent to the old tunnel. And then our interference screw will fix both the graft and secure the dowel, which is already secure itself. We can also do this in other cases, such as a PD ACL reconstruction, where we place this too anteriorly. We place the dowel, and then we place our new tunnel behind that. We did a study of the single stage technique and found the patients did reasonably well for revision ACL. Keep in mind, revision ACL is never as good as primary ACL reconstruction. Sometimes, however, you have to do a two-stage ACL reconstruction, and that's a tough sell to the patients because they don't like that option. So when you do that, you have to be very careful in your discussions with the patient and explain to them that they'd rather have two stages that ultimately results in a success rather than one stage that results in a failure. Here's an example of a two-stage reconstruction. Again, the CT scan is the preferred imaging modality, showing 15 millimeters plus of tunnel widening in this case. So again, we can put the femoral side and debride and serially drill, and then we can place our bone dowel into this previous and expanded tunnel, the press fit technique. And then when we do that, we see that the dowel's in place. And then in this case, here's another case that's very happy with this dowel inserted. And you can see the plug in place. Now, there's alternatives also. If you have too big of a tunnel, you don't necessarily want to go by the articular surface of the condyle when you're placing this in. And therefore, you can do this transtibially, especially if the previous reconstruction was done transtibially. And so you serially drill and prepare the tibial tunnel. And then, because the femoral tunnel is often smaller than the tibial tunnel after these problems, you can place the dowel through the tibial tunnel and into the femoral tunnel transtibially. Obviously, you don't want to fill your tibial tunnel until you put your femoral tunnel in through it. You can also go retrograde. So you can place your guide pin in the location you want it, serially drill, and then put the dowel in from outside to in, retrograde. Here's an example of that. We're placing this dowel down this tunnel and back into the previous tunnel. Again, the tibial side, serially drill, and then tunneloscopy shows nothing but bone. And then you can place your dowel, or dowels in this case, into that defect. Here we are placing a dowel into that expanded tunnel that we have serially drilled. Here it's a little prominent. So what you can do is take a burr and just kind of smooth that out. And then you have dowels in both the femur and the tibia, and you just let it heal in before you come back for your second stage revision. So we get a CT scan again at least 4 months after the primary procedure, and we can study it. And so in this case, we use the dowel in the tibia, and then because we had a little extra tunnel, we decided to put some demineralized bone matrix in there that has chips in it. And it turns out the DBM and chips doesn't heal in as well as the dowel. So I don't use that technique anymore. And so we now use 2 plugs if we need to, or just a long 1 plug. The plugs are now available in longer sizes. Here on the second stage, we see the dowels integrated. Here in the tibia, you can't even tell where the dowel was. And then here's our new graft in the second stage. So we looked at this incorporation on CT scan, and we showed that our bone dowels heal in just as well as iliac crest bone graft. Here's a CT scan showing the integration of the dowels at 4 or 6 months. Here we can see a 3D CT study, which we're now doing an evaluation on, showing very nice incorporation of these dowels. And in fact, it's interesting, you can still see the cannulated portion down the line. Defect and then fill. And then we also have done some histology evaluation. We've biopsied these dowels at intervals. Here's time 0, demonstrating, as I suggested, 0 cells, which is something you want because you don't want a reaction from the host. Here we see the biopsy at 4 months, demonstrating good integration of the dowel with the host bone. You can see a new cement line. The host bone has cells. The dowel does not at 4 months, but it's good integration. And then we biopsied at a year, and here we see good integration and repopulation with host cells. And so this doesn't happen when you use calcium phosphate or other techniques. So we're studying and comparing calcium phosphate with the bone dowels. And so far, at least at our institution, the bone dowels appear to be a better choice. Now, I think we have plenty of time for some cases. And so we can share these cases with you and go through them. And as we go through them, I would encourage you to think about what you would do in each case. So the first case is a young undergraduate female from the university who had a previous ACL reconstruction with a so-called APR-fix device. If you're not familiar with this device, it is a plastic, used to be metal device that you can expand the fins on using a screwdriver that allows fixation in the femur. So this fixation device, although it was good idea on the drawing board, makes it very difficult in revision settings. So the patient had this injury, and it's not unusual that when you get an MRI of this case, it will show supposedly that you have an intact graft. But you got to remember that the MRI just shows whether you have tissue there. It doesn't show whether the tissue is functioning. We could not get a CT scan approved by insurance because the MRI read. So we went into this with several options. Here is this APR-fix device. You can see that it's plastic or PEEK and then expands the fins when you use a screwdriver. Here is the pre-op x-rays demonstrating this device. And you can see this presents a challenge. We did have the appropriate screwdriver, but as expected, when you use a screwdriver, it doesn't always undeploy the fins. Here's the MRI.
Can we ask?
Yeah, go ahead.
Don't you think the tibial tunnel was very much backwards? On posterior?
The tibial tunnel, yeah, the tibial tunnel is somewhat posterior from where I like it. Yes, the tibial tunnel is more posterior than we'd like. That's right. Correct. That's right.
So because then the graft will become short and chances of breakage will be more, I think. I don't know.
Right. No, that's a good point. We'll show you what we did about that.
Yeah.
Okay, so here's the graft. You can see it's not functioning. By the way, I would encourage everybody to speak up like that. That's perfectly good. I like that. So here we are taking out this PEEK device and the tibia. You can see the plastic device where we pulled out of there. And here's the screw that we backed out on the femoral side. And then here we are with the location where they had placed that previous tunnel. And actually that location is pretty good. I like to be about 3/4 of the way across Blumenstadt's line and below Blumenstadt's line. And so that tunnel that they placed on the femoral side is going to be adequate for our revision. But you're right, the tibial tunnel is too posterior. So what we did then was we put a dowel back in that posterior tunnel and then planned for a new tunnel anterior to that posterior previous tunnel. So you can see the dowel in place on this fluoroscopic image. And so then we placed our new tunnel anterior to that, and we're able to do a one-stage revision in that case. And here's our one-stage ACL reconstruction with patella tendon autograft. So that's the first case. Do we have any comments or other discussion about that case?
I think if so far so good. If there are any, then we'll cover it in the Q&As, please. Thank you.
The problem is that we do not have such facilities, you know. What we have to look out is for all the time autographs or bone graft from the iliac crest or upper part of tibia.
Right. So in that case, you're probably going to end up doing more two-stage revisions. You're probably not going to be able to do one-stage revisions as frequently if you don't have these dowels available.
I would like to have your opinion about the bone patella bone.
About, I'm sorry, what?
BTB graft for revision.
Yeah.
Or
so
PQT.
yeah, so I think both patella tendon and quadriceps are turning out to be better grafts than hamstrings, at least in the United States.
So, I mean,
I am sure.
Yeah.
Okay.
So, Dr. Miller, what we'll do is, yes, we'll certainly come out with questions, but we don't want to stop your flow. And then we, you know, step by step, we have a lot of questions to cover up, really. Thank you.
Okay. Well, you just tell me when to stop. Okay. I'll go into the second case, but if you tell me when to stop, we'll stop for questions.
Perfect. Thanks a lot. Thank you.
Okay. So let's go to case 2. So case 2 is also a young female who has pain with running, had a repair of the ACL. So this is becoming popular, at least in the United States, is to try to do a repair, primary repair, and then to use what's called use some type of soft tissue cortical fixation to act as a shielding for this, a so-called internal brace. Which a company has popularized and so advocated for this. And there are some people that are doing quite a few primary repairs. Our results, as this case will show, suggest that a primary repair may not always be a good choice and may not hold up with time, but we can discuss that later too. So anyway, this patient did well initially, but then several years later, had a gradual loosening of this problem. So they had loosening of the primary repair over several years. And so here you can see the original injury 4 years previously. You can see that the ACL was torn almost directly off the femoral side. So this is, according to the proponents of primary repair, an ideal case to attempt a primary repair. You can see this was done in 2015, so 4 years ago at that point. And so this was a Sherman 1, which means torn right off the femoral attachment. And so what we did was we attempted a primary repair. This is something I did. Here is the internal brace, which is the suture used to help supplement this. And so this did well for at least 4 years. And here, 4 years later, they re-injured it through gradual attrition. You can see here that the tibia is anterior to the femur, which is what the radiologists call a drawer sign. We'd probably call it a radiographic Lockman sign. And when we went back in to fix it, you can see this is the internal brace. So the internal brace ultimately failed, as did the ACL reconstruction or repair. And so
was
this
it
is a
clinical infection?
I'm sorry?
Was there any subclinical infection in this case?
No infection. We actually took cultures and found no infection. Now, again,
Okay.
Isn't it
Again,
true
maybe
that,
polymerase chain reaction would have shown something, but we don't have that available for routine cases.
Dr. Miller, while this point was raised, isn't it true that if there is infection, it will fail in the first 3 months? And if you have a late failure, 4 years down the line, it wouldn't be infection or technique related or hardware related.
Well, that's generally true, but again, there's whole bunches of causes of failure. And so we wanted to make sure it wasn't infection. And indeed, we did not have that, but I think that there's a problem inherently with a primary repair of an ACL that prevents it from healing. And so I think that all this excitement about primary repair is going to fall the same way that the initial attempts to do primary repair at West Point will. With longer term follow-up, it's going to show more failure, even with an internal brace.
Absolutely. And as you said, this technique is constantly evolving in terms of the fixation methods. Now, one point I would like to just state regards this patient selection. Now, she's a young patient, active. Now, generally, the indications of the proponents of the repair say that you need to have somebody who's less active and probably middle-aged. So would that be one sort of, some sort of decision-making in retrospect?
Well, here's the deal. The funny thing is, the reason it may work in the patients that are older and less active is because they don't need an ACL reconstruction at all. And so, yeah, you self-select your patients that don't really need an ACL, they're going to do great. And so the question is that we need a procedure for somebody young. And so if this doesn't work, we shouldn't be doing it at all.
Sure.
Dr. Miller, I have been doing ACL repair, the femoral eversion, but we are not using this tape or anything. I am using a gracilis as an internal brace. And it has given at
you're
least
doing a hybrid, basically repair and reconstruction?
Yeah.
Yeah.
And we have, means it has been, now I have a couple of patients, like 27 patients of ACL femoral eversion reattachment or repair. And we are not seeing that failures. Of course, our patients are not having athletic population. Most of them, they're recreational people. But do you think that that is making difference if we repair because they are not high level athletes or high level people?
Well, that sounds encouraging. I haven't heard of that technique. I would encourage you to follow those patients and publish that.
Okay. Okay. Right.
That's good. All right. So we talked about the Sherman classification. So if you're going to do repairs, the best case is this type 1, where it's actually avulsed off of the femur. So as you get more in the mid-substance, you're more likely to have a failure. So DeFelice from New York has been a proponent of this, and he has short-term follow-up with good results. But the problem is that, like this case, longer-term follow-up really is going to be required. And the other point is that Martha Murray from Boston has also advocated this, even in young patients like adolescent patients, but she's using a scaffold, a special scaffold that may bring in more healing factors. So we will see. I just show this case to suggest to you that you shouldn't do this routinely, and there may be problems with it. So let's move on to case 3. This is a middle-aged patient, if you will, or older patient, slightly older patient, who had a twisting injury and had a previous ACL reconstruction done previously in about 10 plus years previously. Again, loose on examination. And here are the radiographs. And so I don't think it takes too much skill to recognize that this femoral tunnel is obviously vertical. In fact, crazy vertical. And then the tibial tunnel is has some osteolysis or tunnel widening. And so again, MRI can be very difficult to interpret, but a CAT scan is very helpful. So here the CAT scan showing the tibial tunnel with 15 millimeters of osteolysis. and it's slightly posterior to where you want. So again, we talked about the indication of 1 versus 2 stages, and I would suggest to you that if you have this much osteolysis, and especially if you don't have any dowels available, then you should probably do this in 2 stages. The femoral tunnel is not going to be a problem because it's too vertical anyway. And so the other problem with this case is that the patient has 15.5 degrees of posterior tibial slope. So let's go back and look at these radiographs again, and you can appreciate how this patient has some slope, and there's some ways to measure that, including placing circles in the tibia and then drawing an angle up. And when we studied this, the patient had 15 degrees of slope.
May I ask you?
Sure.
The opposite knee must be having the same slope, right?
Yeah, well, we didn't really study that. That's a good question. And so the other knee had no problem. So if this catches on, maybe ultimately we can be doing osteotomies for people that have intact ACLs to avoid ACL. But that's going to be a tough sell. We'll have to see how that goes.
Yeah. Okay.
All right. So anyway, we planned for a 2-stage revision with an osteotomy in the first stage and bone grafting of the defects, and then we go back for a 2nd stage later. So here, arthroscopically, the ACL is lax, no new meniscus tears. The prior tunnel on the femoral side was so vertical, we didn't even need to worry about it. And the tibial tunnel, then, we can center our guide pin, serially ream until we have nothing but bone in the outside of it. Again, cultures were taken, no growth. And then we're planning our closing wedge anterior osteotomy. And then here's our bone dowel in place in the tibia. And here is after our osteotomy. You can see before and after our closing wedge osteotomy. We actually close this osteotomy with bioabsorbable fixation. And that way I don't have to worry about coming back later and taking out all this metal. We had no metal. Protective weight bearing, wait for this to heal up, and then go back for our revision down the line at 4+ months. So that case isn't finished yet, but I wanted to show you what we're up to and what we're doing. And so let's review what we've talked about. We talked about some introductory comments and some causes of ACL failure. We focused on osteolysis or tunnel widening. We talked about 1 or 2-stage techniques. We talked about some of our CT studies and biopsies, and then we showed 3 cases. So now we have plenty of time to discuss whatever you choose to discuss, and I'm happy to be open for any and all questions as we ride out into the sunset at the end of this discussion. And I'm available for questions.
Like your cartoon, last cartoon, very good.
Great. Thank you very much, Dr. Miller. That was an excellent overview of revision ACL reconstruction. Do any of my colleagues who are logged in have any questions?
Yeah.
Yeah.
No, so the thing is that you never discussed about the lateral laxity or PLC corner, about the failure. You just mentioned once, but here in India, the people, they sit on the ground and they sit cross-legged. So one of the failures, reason for the failures is not recognized posterior corner insufficiency in the initially where the ACL was done, and that is why it also gives a lot of patients for revision surgery.
Well, that's we don't see that as much, but we have seen that. But that's good that you recognize that. Again, it's really important to do a careful exam, including assessing for asymmetric external rotation, so-called Dowel test. Yeah, Dowel test. And we like to do stress radiographs also to show varus laxity. And if you have that, then absolutely you should do a concurrent posterior lateral corner reconstruction at the time of your surgery. You're right. That's good.
Yeah, I mean, that's a valid point because a lot of time the MR imaging may not be reported as a PLC. So what we rely on is a combination of clinical exam and imaging. So while we are at imaging, because we have a wide audience as far as the Indian Arthroscopy Society goes, right from a resident fellow to a junior consultant and to an experienced consultant, what would be the basic imaging you would do if you were to approach a patient for a revision ACL?
So you obviously need to get plain radiographs, AP lateral and sunrise. I think a flexion weight-bearing radiograph's helpful looking for subtle arthritis. A long leg axial alignment film from hip to ankle bilaterally to look for abnormal mechanical axis in planning for osteotomies. If you're considering an osteotomy anteriorly, you should also get lateral tib-fib x-rays so you can measure more accurately the slope of the tibia. And then move on to stress radiographs if you suspect some laxity or if you have a posterior lateral corner injury you're thinking about, especially in your society. And then advanced imaging, which consists of MRI, and I routinely get CAT scans when I can to evaluate for tunnel osteolysis. So quite an extensive amount of imaging.
Right. But it's crucial, as you said, to determine any tunnel widening or the bone quality and invasion, the CT scan plays a very important role. Now,
there's no doubt about it.
Yeah, absolutely. So now when we talk about imaging, so we mentioned about the slope being a very important factor as one of the causes of failure. Now, all these studies talk about the medial slope. Now, when we talk about high-grade pivots, one of the causes is that the slope on the lateral tibial plateau is the one which is of more concern. What, in your experience, how important is it to measure the lateral tibial plateau, whether it lies within the acceptable limits?
So we're actually studying that right now, and it's interesting because you can't always tell on a plain radiograph which plateau you're measuring, and that's where CT scans coming in. And so I think over time we're going to be able to develop protocols for CT evaluation to be able to differentiate where the slope issue is, and probably you're right, lateral is going to be more important than medium.
Great.
May I ask something?
Sure.
Yeah, please do.
Yeah. Mark, the last case where you did osteotomy, if you had not done osteotomy and did a revision, what would have happened?
I missed the last part of that.
If you had not done osteotomy and if you had done only revision ACL surgery, do you think there was a high chance of failure in the osteotomy patient?
Well, yes. I think that if you're going to do a revision, you should do everything you can to avoid another revisions, because the more revisions you have, the more likely you're going to continue to have failures. So if you identify all the causes of failure, you should try to correct all of them at the same time, even if it takes 2 stages. So yes, I think it's critical. Now, if it's close to 12 degrees, you might be able to get by with an extra articular augmentation rather than an osteotomy. But anything more than 13, 14 degrees, I think you should do an osteotomy.
Okay. But
now,
then you
have
accurate accurate measurements, you have to have.
Yeah,
so how do you measure this by CT scan, by plain radiograph? How do you measure this?
We start with plain radiographs, and so if you're really concerned about it, you should get a long view, a lateral view of the entire tibia.
Yes.
And then you place perfect circles inside the cortex, stacked circles, at least 2 stacked circles, and then take the center of those circles, draw it up to the tibia plateau, and then measure the angle on the tibia plateau on the plain radiographs. As I indicated, sometimes it's hard to tell whether it's medial or lateral plateau, but this gives you a pretty good indication. And then CAT scans, we're currently trying to develop a protocol for that and haven't come up with it yet, but hopefully we'll have that soon.
Do you have any picture of the what you described on the plate radiograph? Do you have any?
No, I don't have that in this talk, but it would take me some time to find that. But I have it somewhere, but I can get with you later if you send me an email.
Okay.
Now we're
Yes.
talking about the slope measurement. It can also be done on MRI. So in your experience, how important is it on an MR imaging versus a radiograph? Obviously, the condyles have to overlap and it has to be a true, sagittal image. But what do you think? Is there a difference?
We haven't studied that. I think that's a good question. In general, I think that CT scan is best for bone. And it's the same thing with osteolysis. And so people describe trying to use MRI for osteolysis. And I really think a CT scan is the best study, both for osteolysis and for the slope. And so we'll continue to explore that.
Okay, Ranjit?
Yeah, Shreyash, I have one question regarding the patient selection. Yeah, Dr. Miller, it was a very good talk and an excellent talk. So sometimes we find grade 1 laxity in some of our patients, even after 6 to 9 months of surgery, in spite of undergoing a good rehab program. Otherwise, the knee is stable, but still the patient is not feeling like both the knees are similar and they avoid their previous activity level. Now, do you mark these patients as failure of ACL, or you add some other procedures to make him join to the previous activity level? What is your opinion?
Well, this is something we're all struggling with. It's very difficult to get an ACL perfect. Okay, we all know that. And so the key issue is clinically whether the patients can, are satisfied with their knee, and at that point they either need to decide to modify their activities, or you swing for the fences. And so it's very difficult to make things perfect. So I don't recommend revisions unless, people have, significant side-to-side instability, significant lifestyle problems, and objective measurements of laxity. And so it's very difficult to chase these in these patients that have subtle abnormalities. So that's a tough call, and it really boils down to a patient by patient choice.
Right.
Okay.
Miller, okay.
Another question is about graft choice and sizing. Now, when you in India, generally the hamstring is the graft of choice. So if you were to do a revision in your setting, and if it be an autograft, I know you use a lot of allograft, but if it was autograft, what would be your graft of choice for a revision? Would it be a contralateral hamstring, or you'd go for something else?
So in the United States, we prefer, in general, patella tendon or quadriceps graft for even primaries. And so just like in primary ACL reconstruction, however, autograft is favorable over allograft in all cases. Much higher failure rates, even in revisions with allograft. And so if we have a previous hamstring, that's easy. I go to patella tendon from the same side. It gets challenging when you have somebody who has already had multiple grafts from their side, if you're in your second or third revision. And that's challenging because you're running out of grafts. So I have no problem going to use the quadriceps if somebody's had a previous hamstring and patella tendon. I can go to the quadricep on the same side and haven't had any difficulty with that, particularly if people bone grafted the previous patella tendon harvest after they closed. And so that works out well. The nice thing about the quadriceps tendon in my case, I like to take a piece of bone graft with it, and that way I have bone-to-bone fixation, and I put that usually in the femur. And then on the other side, the quadriceps is a beautiful graft because you can actually tease out the various components of the quadriceps and end up with 4 different tendons. And therefore, I like to use a screw and sheath construct to secure those 4 tendons in the tibia. And so I've been going more and more to dividing those grafts into 4 quadrants, and then using the screw and sheath construct, which is available by multiple manufacturers, and that gives really secure fixation. So I'm really happy with that. So if you've had hamstring, patella tendon, and quadriceps tendon grafts before, then you got to go to the other leg.
Right. Okay. And in terms of graft size, would you have a certain minimal quadruple graft diameter for a revision?
Yeah, sure. So just like in primary, the primary work was done at Duke University, and they showed that any graft that is 8 millimeters in diameter or less had a higher failure rate. So I suspect that's pretty common if you guys are using hamstrings as much as you say. And so,
But
in
that
those
is
cases, we've actually published on this.
right?
You have to either supplement this with a allograft or with a contralateral hamstring. So many cases I prep both legs and go get an extra hamstring from the other leg.
Sure.
Well, how about peroneus?
We have not used that tendon.
So yeah, I think you should give a try to it. It's a beautiful graft. I think so.
How about the donor site morbidity?
No.
Yes, absolutely. And you know, these newer graphs have we don't know what the long-term results are, because I'd just like to bring everyone's attention that in the ESCA journal this year, the Danish registry has published their results of primary ACL using all types of graft, and they found a high failure rate with the quadriceps tendon graft. So, you know, generally the hamstrings and the bone patella tendon are really time tested, but things like peroneal or quads tendon, we don't have long-term follow-up. So it really has to be kept in mind when we try and go for different grafts. Unless, of course, it's a multi-lig situation, and then we don't have a choice. We have to go for a lot of grafts. So that's something to be aware of.
Yes,
Dr. Miller,
we are talking about revision, right? We are not talking about the primary.
Yes, but we don't have long-term follow-up for peroneus, so it'll be a little experimental to try.
Bancha has already published 5-year results.
Yes, I mean one center, but we don't have it across, so it'll be worth seeing. Whereas the contralateral hamstrings has a very long-term record, so it'll be a popular choice in the first revision setting. Now, to asking about fluoroscopy, Dr. Miller, that is a very important point, because a recent publication in the AJSM also showed that high volume ACL surgeons, the fluoroscopy was the most accurate way to actually locate your center point. Would you also use it in your primary setting?
Yes, I do it routinely. And we started this when we've done some clinical studies trying to determine accuracy of landmarks for the tibial tunnel. And so when we studied that, we actually also looked at the femoral tunnel by retrograding the pin out and took an x-ray that included both the femoral tunnel and the tibial tunnel. So our study showed that that there are no reliable landmarks for the tibial tunnel arthroscopically, and therefore fluoroscopy was helpful. Now, what we also found was that, without planning this part of the study, that about 20% of the time we actually didn't like our femoral tunnel when we're looking at our tibial tunnel. So we adjusted the femoral tunnel accordingly. And so we weren't planning on that, but that now I use it routinely because of that finding.
What is the learning curve with this device?
It's really, you just got to get a perfect lateral radiograph intraoperative. So you routinely, it takes several shots to get it perfectly where the condyles overlap.
Right.
So you don't have a software to have the quadrant measurement.
Oh, well, you can just eyeball that. You don't need software. You can just eyeball that.
Okay, that's great. Okay.
Yeah, Dr. Miller.
Yes, Rajit.
Yeah, Dr. Miller, how you do your space management in single stage revision procedures? I mean to say, when we are going for a single stage revision procedure, so we usually require a larger diameter graft than the primary one. And now in every cases, you do the notchplasty and create the space, or how you manage your space in a smaller knee with limited space in case of single stage revision procedure of ACL reconstruction?
Well, when I never go into a single stage ACL reconstruction promising in a patient that I'll do it in one stage. So you always have to be prepared for having to do it 2 stages, because sometimes you just never know how big that tunnel is going to get. And so, you know, I tell the patients, I say, look, we're going to try to do this in 1 stage, but I may not be able to. And so therefore, as we serially drill and we get our tunnels, and if it's too big, then we just have to do it in 2 stages. And so I think that's the answer, is never promise a patient you're going to do it in 1 stage. And if you get too big of tunnels, then go back and wait and do it in 2 stages. So I try not to put too big a graft in, because if I do, then first of all, it's technically difficult to get a big autograft that big. And second of all, it's not going to work.
Can we do a hybrid, single stage, like you put a graft and then fill in the defect with the bone graft? If it is the is larger, you know.
That
Because
works
problem
as
is
long as you don't. Yeah, go ahead.
people, they do not come again. They don't want to come again and again for the surgery in this country. That is the biggest problem that we are facing. So I was thinking whether can we do hybrid type of, because we will do both extra cortical fixation, you know. We don't have to do internal fixation of those grafts in the revision.
Well, again, if you think that you can do it in 1 stage and you're not going to compromise your other tunnel, and you fill your other tunnel, then sometimes you can do it. But again, if you have too big of a tunnel, no matter how much fixation you put in there, it's not going to be as good. So you can see these people that put 2 or 3 screws in there. That's not a good idea. That more often than not, that fails. Yeah.
Correct.
Yeah.
Now, when you go in this revision situation, do you preserve whatever is the remnant of the ACL graft, or we need to just clear it out? Is there a role?
Yeah, in a revision setting, I don't try to do. See, you're not preserving necessarily any viable tissue, so it's not like a primary, you know, where you try to save some of that for, you know, integration or proprioception. In a revision setting, I get rid of all of it, because it's not working. It's dead.
Sure, that's a great point. Now, in the high-risk group, would you do an extra-articular procedure alongside a revision ACL, or would you do an extra-articular almost in every case or every alternate case? How do you choose?
Yeah, that's a great question. And so we're studying that even with primaries with the new study out of Canada and Pittsburgh. So the Stability 2 trial. The Stability 1 trial showed that augmenting hamstrings was beneficial, even in primaries. And so we're studying that now with different grafts. So the answer is, as of now, I tend to do it more often in revisions, but not always. And so my thinking is, if you have a giant pivot shift, or the patient's failed more than once, or, you know, the tunnels looked okay, but it still failed, then I'll do a extra articular augmentation. And so I think probably over time, we're going to be doing that more and more often, and may end up doing it for every revision.
And you do a modified Lemay?
Yes.
So how do you kind of escape from tunnel coalition? Because you have a lateral.
That's a great question. We worry about that all the time. And so what we're doing is we're very carefully choosing our point, and then aiming our pin anterior and proximal to avoid the ACL tunnel.
Okay, that's great. Fantastic. Now, have you come across any revisions for a primary double bundle ACL reconstruction done? And how difficult or how easy is that?
Yeah, I have, and it's very difficult. This almost always requires 2 stages, and so you gotta fill up 2 different tunnels, and so you don't want to create a third one. So it's a challenge.
Outside in? Do you go to outside in also?
That's a good option too. So you want to, when you're doing a revision, you want to avoid converging tunnels or tunnels in the same orientation. So if somebody did a inside out, and then you can try to diverge your tunnel by going outside in, that's a good option. And so you want to diverge your tunnels whenever possible, but also fill up the old tunnel if you need to, so that the graft doesn't migrate into the previous tunnel.
Right.
In terms of post-op rehab, is it any different from a primary ACL?
Yeah, even our primary ACL reconstruction rehab has changed. And so we're doing so-called decelerated rehab. In other words, Shelbourne popularized the accelerated rehab. And so there's no such thing as accelerated rehab in our mind. And we've done a lot of studies and are publishing them now about testing patients before return to play. What we found is that it takes not 3 or 6 months, but more like 9 to 12 months to get quadriceps restored. And so return to play rapidly is unusual and hazardous.
Right.
So how do you manage the elite athletes in terms of return to play then?
Same thing. We study them with strength and then functional drills.
Okay,
Right.
and you're in control and not just the sports physios, because a lot of time there's pressure from the club physios to get the athlete going. So you take charge of events?
Well, this studies allow us to give science and objective data to coaches and trainers and administrators so that we have objective data to direct return to play rather than pressures of the sport.
Great.
Yeah,
And-
Dr. Miller. Hello.
Yes, Ranjit.
Yeah, Dr. Miller. What is your take in the meniscectomized patients? Say in the primary ACL reconstruction, someone has done the meniscectomy of a bucket handle tear and most of the posterior horn. Now, when you are revising, how you address those patients? Do you think of again meniscal transplant kind of thing, or your intralateral reconstruction compensates for those cases? In meniscectomized patient, how you deal with the revision surgery?
Yeah. So again, this depends upon the patient, the age, the activities, etc. But we all know that the posterior horn of the medial meniscus is an important secondary stabilizer for the ACL. And so there are cases where I recommend meniscus transplant as part of that revision. And so this often also necessitates a two-stage approach. But yes, in elite athletes that have a significant loss of meniscus without significant cartilage loss, then that's a very important consideration. And I have done that on numerous occasions.
Great. Dr. Miller, a revision in a female with, say, a hyperextension of 10 degrees or more, how do you tackle that?
Right. So with hyperlaxity, this I would advocate for patella tendon grafts in that case, bone-to-bone fixation. And so that, in my mind, is an indication for patella tendon graft, hyperlaxity. And then, in addition to that, you should consider, especially in a revision setting, that's also an indication for an augmentation.
Okay, great. Any other questions from the panel?
Yeah, Dr. Miller, when you have one non-anatomical this tunnel, say on the femoral side or tibial side, and other side it's an anatomical tunnel, and it's smaller size, say you can go with the single stage revision. So you go in a single stage, or where there is a non-anatomical tunnel or a partially anatomical tunnel, you go with the bone dowel and then you come and do the surgery, second stage.
Yeah. So again, this depends upon the size of the non-anatomical tunnel and where it is in relation to where you want your new tunnel. And so if you can fill that previous tunnel at least and not overlap by more than 40 to 50%, then you can do it in one stage. But if you're going to compromise your new tunnel by the old tunnel and you can't fill it at one stage, then I never hesitate to go to 2 stages.
Okay. Thank you.
Great. Anything else? Any other questions? Great. Dr. Miller, I would just like to thank you from the bottom of my heart, both personally and on behalf of the Indian Arthroscopy Society. It was a wonderful lecture. You've shared your experience and you've been very patient in the Q&A section. Yes, Dr. Nishit has one question. Please go ahead.
Miller, I think you were in Wake Forest, right?
No, I'm at the University of Virginia.
No, previously? No.
No, I was in the Air Force before coming to the University of Virginia.
No problem. Yeah, I understand.
Great.
But it's
So,
very to hear you and your experience. Okay.
Great
Go
job.
ahead.
As you heard, we are all very grateful and thankful for your participation. We've learned a lot, and certainly we look forward to connecting with you and meeting you at some point in the future, personally from my end. Thanks
Let's
very
have
much.
some live meetings.
Great, yes. Thanks very much, and take care.
Thank
Thank
you.
you.
My pleasure. It's been a pleasure.
Thank you.
Thank you. Bye.
Yes, bhai, maja aayegi.
Thank you.
Sir,
Maja aaya. Yes. Some good points.
yes,
Yes, absolutely.
Yeah.
Sandeep, go on.
yes. Good evening, friends. So this was a very informative and very nice lecture. So we have our next webinar coming up on the next Tuesday. That's on 18th August. It's a very fantastic topic by a radiologist, Dr. Aditya Daptari, who specializes in musculoskeletal radiology, and our own Indian Arthroscopy Society member, Dr. Sajir Usman. It will be on clinical and arthroscopic correlation of the knee MRI. So stay
Good.
tuned on 18th August at 7 p.m. Thank you very much.